Okay, the next speaker is a special guest from Netherlands, Dr. Walter Noordzij. Am I pronounced correct? He's a
yes, good morning.
Good morning. He's a nuclear medicine from University Medical Center, Groningen, in Netherlands. Dr. Noordzij graduated from Recht University as a medical doctor and finished the PhD program in University of Groningen. He is an excellent researcher, mainly in the field of oncology and cardiology, but also a very nice educator. He participates a lot in the medical education and resident training. Today, he will share the clinical experience with digital PET scanner. Let's welcome Professor Noordzij.
Well, thank you very much for the kind introduction. Good morning. Actually, I'm in Jeddah, Saudi Arabia right now at this moment because of the Society of Intervention Radiology in Saudi Arabia. So it's not too early for me. Fortunately, it's 7 a.m. in the morning, so that's rather okay, instead of 5 a.m. in the Netherlands. So yes, I will be talking about the clinical experiences with our digital PET-CT system, which was installed already in 2018. These are my disclosures.
Sorry to interrupt you. So we have not yet see your slide.
We did not see your screen yet.
Okay. So, try it again.
Yes, it's okay.
Okay, excellent. Okay, sorry about that. Okay, so we have installed a Siemens machine. So we were experienced with Siemens MCT, Biograph MCT systems, and we have installed in 2018 the Siemens Biograph Vision. And the most important improvement of the digital PET-CT compared to these analog predecessors actually within the detectors, because there is now this full coverage of these compact square size detectors, leading into several types of improvement in both image quality, but also image characteristics. So if you compare the, for instance, time of flight, but also the resolution and the sensitivity of camera systems with, on the left-hand side, the analog, and on the right-hand side, the digital PET-CT system, you can see that there is an enormous improvement in the time of flight from over 500 to, well, nearly 200 picoseconds, with also an improvement in resolution from approximately 5.5 millimeters towards just above 4 millimeters, and then nearly a double increase in sensitivity up to 16 kilocounts per megabecquerel. And it's a very stable system as well, because along the entire noise equivalent count rate, from high counts to actually rather low counts, you can see that the noise equivalent count rate stays just above the 200 picoseconds, resulting into actually a very, very stable system. So with only just a very low count rate, but also a very high count rate, the noise equivalent count rate is still the same. So I would like to move into some of our clinical examples from the technical and the clinical validation of this camera system. And then it's good to know that we in our institute, the University Medical Center in Groningen, use a very solid image protocol, which is actually based on the European Association of Nuclear Medicine guidelines. So of course, patients have to be in a fasting state for at least 6 hours. And we always administer 3 megabecquerels per kilogram body weight of FDG, of course. And we perform our acquisition 60 minutes after administration. And we scan patients between 60 and 90 kilograms of body weight during 2 minutes per bed position. And patients over 90 kilograms, we scan them in 3 minutes per bed position. The patients less than 60 kilograms of body weight only in 1 minute per bed position. Of course, we make an attenuation CT for correction and a separate contrast-enhanced CT scan for selected cases, for instance, in lymphoma, esophageal cancer, lung cancer, but not in all cases. And our standard reconstructions consist out of an Ultra HD reconstruction, but also reconstructions based on European guidelines for SUV determination. So for our clinical validation, we had selected, maybe 100 cases to compare image quality of our analog system to this digital system. And I would like to share the images of this male patient, 35 years of age, with a medical history of sarcoidosis in lymph nodes in the mediastinum, and was now suffering from pain in the knees and the shoulder blades. And that was actually the reason for acquiring an FDG PET scan to see if there is a relation to this sarcoidosis. So we first scanned our patient on the MCT system, showing, of course, the FDG avid lymph nodes in the mediastinum, but also in the right axilla and underneath the diaphragm. But not so much an explanation for his pain in his shoulder blades. And we moved this patient from our analog system to our digital PET-CT system. So actually there was only nearly 30 minutes between scanning on the MCT and scanning on our digital PET-CT system. As we acquired the image of our vision PET-CT system, we were actually a little disappointed in the image quality. Of course, again, this image here on the left-hand side was acquired in 3 minutes per bed position. But when we look more closely to our image, our acquisition parameters, we saw that we actually made a mistake in keying in the acquisition parameters. So this image here in the center was acquired in 7 seconds per bed position instead of 3 minutes per bed position. So this scan was performed within 1 minute. And after adjusting the imaging of the acquisition parameters, we rescanned the patient. So again, approximately half an hour after the administration on the MCT or acquisition on the MCT, these were the images from our digital PET-CT system. There is a sharper demarcation of the several lymph nodes in the mediastinum, sharper demarcation in the right axilla. You can actually see more clearly the FDG avid lymph nodes underneath the diaphragm, but also the sharper demarcation of the organs not involved. Another case, another male case, 48 years of age, with a medical history of planocellular carcinoma 2 years before the acquisition on our, or referring at that time point, which was initially treated with chemo and radiotherapy and had 9 cycles of immune therapy because of a progression of disease. And so this PET scan was performed because of response evaluation. And on the top row, again, you see from our analog system, conventional PET-CT system, with underneath acquisition on immediately afterwards on the vision with different types of reconstructions. And of course, the same is true as in the previous patient, a sharper demarcation of the several lesions, especially here underneath the diaphragm, and changing the amount of iterations and subsets does not really change the image quality, and actually adding a filter, a 2 millimeter Gaussian filter, doesn't end up in real differences in image quality. But it's always better than on the analog PET-CT system. Another case, 77-year-old female patient with a history of polymyalgia rheumatica, treated with methotrexate until 2016, and actually was suffering from complaints of reactivation of the giant cell arteriitis with the rise in her C-reactive protein and the erythrocyte sediment rate. And the FDG PET scan was performed because of evaluation of the extension of her current disease. And what was nice on upon acquisition on our digital PET-CT system is that of course, you can see the intense uptake in the aorta, but also the subclavian arteries, the carotid arteries. But it seems that you can actually distinguish the deposits of the inflammation along the larger arteries, and also very clearly see the interspinosal activity, which is actually pathognomonic for polymyalgia rheumatica. And if you look more closely to the images, especially the transaxial images, you can actually see the course of smaller arteries which are involved in the disease here on the images from the digital PET-CT system compared to the analog system here above. So the sphenopalatine artery, which usually isn't supposed to be involved, is actually taking up FDG in the wall very nicely. And outside of FDG, we also have experience with other traces, non-fluorine traces actually. So we have now experience since, I guess, 2016, also with the treatment of selective internal radiotherapy using Y90 microspheres. This is a case of a 59-year-old male patient with a medical history of insulin-dependent diabetes, but also a lung cancer already quite some time ago, treated with chemo and radiotherapy, and was referred for SERT as a bridge to transplant because of his hepatocellular carcinoma originating from a cirrhotic liver. And what I'm going to show you are some post-therapy Y90 PET scans. So here on the top row, again, the images from the analog system, and immediately afterwards acquired on the Vision PET-CT system, and the images underneath projected here upon the pre-therapeutic MR. And you can actually see that the contouring but also the deposits of the microspheres seems to be more clearly delineated compared to the analog system above. And another non-FDG tracer, a zirconium antibody in a male patient, 77 years of age, with a history of breast cancer, triple positive, and at the time of diagnosis already lymph node and distant metastases in his thoracic spine, and now suffering from complaints, back pain, and the medical oncologist was actually worried about a relapse of the distant metastases in the thoracic spine. And we performed a zirconium-labeled trastuzumab PET scan to see if there is HER2 expression over there. And here on the top row, again, images from our analog system compared to the digital PET-CT system underneath. And you can, clearly see the improvement of the image quality, the sharper demarcation and the less noise compared to acquisition on the analog system. So these were all images performed on the digital PET-CT system after acquisition on the analog system. And Of course, you can imagine that your tumor to background ratio will improve if you wait a little longer. So if you have an acquisition 30 minutes after the acquisition on the analog system, so that might be an advantage for the vision if you perform acquisitions, perform these double scans with the analog system first, and afterwards transfer your patient to the digital PET system. So after, I guess, 25 patients or so, we switched the order, and we acquired the images on the vision first and compared them with our analog system afterwards. But in changing this order, there's actually no difference compared to the results that we found before. So actually, there is still an improvement in image quality if you perform your image, so you acquire your images on the digital PET-CT system after 60 instead of 90 minutes. So here underneath again, images from a patient with a distal esophageal carcinoma with lymph node metastases here along the left gastric artery, compared to the same patient, images acquired on the MCT system afterwards, where actually you do not see the intense uptake in the lymph nodes along the left gastric artery as clearly as you see them on the images acquired on the digital PET-CT system. And to confirm that there are actually lymph node metastases, here the FDG image is projected upon the contrast-enhanced CT scan, where you can identify the enlarged lymph nodes, which look actually as lymph node metastases on the CT scan as well. Again, a patient with a polymyalgia rheumatica. Here, images acquired on the analog system on the left, and on the right-hand side, the digital PET-CT system, where it looks like there is not so much the characteristic interspinoidal FDG accumulation in this patient here on the images acquired from our analog system, whereas if you look more closely to the images on the digital PET-CT system, you can actually identify the interspinoidal activity even more. So it looks like that in some selected cases, the digital PET-CT scanner can actually see or identify the disease better than our analog system. This digital PET-CT system comes with some fancy features. For instance, this OncoFreeze acquisition, which is helpful for especially those areas where there is a lot of movement. So you can imagine that you can more clearly demarcate the lesions surrounding the diaphragm, for instance, and have less breathing artifacts in lung cancer, esophageal cancer, metastases to the liver. But it's not only limited to that specific area. It looks like if you use this option of OncoFreeze, you can also see improvement and less breathing artifacts of the more superior regions. For instance, the upper parts of the lung. So less breathing artifacts here for these smaller lesions, which are actually subplurally located. The nice thing about this machine is also that you can play around with your imaging, so your acquisition parameters. So you can perform multi-pass acquisitions and reconstruct towards a scan time of any scan time that you're interested in. So if you would like to reduce your acquisition time, playing around with this multi-pass option is helpful in determining which parameters would fit your center. So what we did is we divided the entire acquisition into 4 passes, and made the summation of those 4 passes and several reconstructions, or 4 iterations and 5 sets, and 3 iterations and 5 sets here on the top row, compared to a reconstruction with only 3 of those passes, so up to 75% of the regular acquisition time. And you can see that there is, no real reduction in image quality. You can still clearly identify the distal esophageal carcinoma in this case, with the paraesophageal lymph node metastases here on the right side of the tumor. And there is actually no visual difference in the demarcation of the normal acquisition compared to, the 75% acquisition duration. And that leaves the door open for more sophisticated imaging acquisition types, like these PET-like reconstructions. Nowadays, we are still performing this image-derived input function here on the left-hand side, but we're now moving forward to study if population-derived input function would actually be helpful and bypass actually the image-derived input function, which saves time, and you do not have to interchange or have your patient lay on the bed, in the scan bed, and remove for another acquisition for a different patient in between. So we have studied the effects on standardized uptake value as well. And these are some results of one of my PhD students, Joyce van Sluis, who actually studied the standardized uptake value in FDG-only PET scans for both tumor lesions and for reference tissues, so healthy tissues. These are Bland-Altman plots from her analyses, showing that actually 95% of all SUV max, peak, and mean difference scores are actually within the 95% limits of agreement based on the Earl reconstructions. So this is actually the comparison of SUVs between the analog system and the digital PET-CT system based on our European recommended reconstructions. These are additional reconstructions which we performed or acquired actually to see if we can make more progress in activity optimization. So we have reconstructed the images of I guess 25 patients in this research project, differing from 3 minutes per bed position to 2 minutes per bed position, 1 minute per bed position, half a minute, and 10 seconds per bed position. And these are still images which are actually without any additional filtering. But if you add a 2 millimeter Gaussian filter, or actually use the reconstructions based on the European recommended guidelines with a 5 millimeter Gaussian filter, you actually see that there is no visual difference between acquisition during 3 minutes compared to 1 minute per bed position. And if you look more closely to the quantification for the 4 iterations and 5 subsets, in general reconstruction, so actually the Ultra HD, the addition of a 2 millimeter filter, or according to the European recommended reconstructions, you see that there is just a merely 5% difference in mean SUV between 3 minutes versus only 1 minute per bed position acquisition. So even the patients over 90 kilograms of body weight can actually undergo a reduction of the acquisition time towards only 1 minute per bed position in our center without resulting into major differences in standardized uptake value. And we made the transition towards reduced acquisition time in our clinic, especially for those cases where there is a special demand. For instance, in this case, there was a patient with metastatic melanoma, and she was unable to physically unable to lay down for a prolonged period of time. So we have scanned her in, laying on her left side instead of in a supine position. And additionally, this patient was pregnant at the time point of scanning. So we do not regularly scan patients who are pregnant. However, in this case of the metastatic melanoma, there was an indication for performing an FDG PET scan over any other imaging modality for the staging of her disease. So we reduced her the administered FDG, the amount of FDG towards 90 megabecquerels in total, and we performed this scan in 1 minute per bed position, resulting into very, very fine imaging quality. And sometimes we have some issues with our cyclotron, resulting into a lower amount of available activity to inject in our patients. And sometimes that's also true for F-DOPA in patients with neuroendocrine tumors. And we had to scan this patient with only 45 megabecquerels of F-DOPA with a regular delay after the administration of 90 minutes and a very short acquisition time of 5 minutes and only 23 seconds, resulting in also, again, a very, very fine image quality. And outside of FDG and outside of any other, let's say, static image acquisition, we have some experience with the transition of conventional nuclear medicine towards PET. So, for instance, performing a bone scan now on our PET-CT systems using sodium fluoride, but also with dynamic acquisitions. So we do not perform a 3-phase bone scintigraphy anymore in our center and transfer that all to a sodium fluoride PET. And sorry. And here on the top, you see the accumulated images of the first 5 minutes after the administration of sodium fluoride, with a diffusion phase underneath, and very sharp images acquired after 60 minutes of a patient suffering from a periarticular ossification, which was actually the complaints, the explanation of the complaints on the left hip. So with that, I would like to thank my team, which was actually responsible for both the clinical and technical validation of our digital PET-CT system. And of course, I would like to answer any of your questions if you have them at this time. Thank you very much.
Okay, thank you for nice presentation. And have any question from our audience? Okay, I have a short question. As we know, the new modern digital PET should have the time of flight technology. So the key issue, the key parameters is timing window. So I just want to ask the digital PET scanner have the ability to adjustment or manipulate the timing window, or it's just only have one option?
If I understand correctly, is your question that you can change the time of flight?
Yes.
Actually, I'm not aware of the option of changing the time of flight from 500 to just 200 picoseconds. In my experience, we perform our acquisitions with the time of flight option always on. So we never perform acquisitions without time of flight. So I guess that our clinical physicists do not actually support switching off the time of flight option or actually altering the time of flight option.
Okay, thank you. So have any question from our audience? Okay. Because we have time limited, so the chair say we have to close the section. So thank you. It's really a wonderful presentation. Thank you.
Thank you very much.